if we have too much ADH, then we're going to have decreased urine output. That, yeah, but I wasn't thinking, but I wasn't going to ask that. Only because polyuria is one of our signs for, you want to see my proofs? But you're not listening to the words from my mouth? Oh, okay. It is signs for diabetes 1 and 2. It was like black cat on Thursday. Okay, so diabetes insipidus. Yeah. So insufficient ADH, which means our kidneys cannot reabsorb water. It's like a huge problem. So reasons for this could be drugs, surgery, head trauma, pituitary tumor. So what I want you guys to kind of keep in mind is that DI is going to come up when your ADH is reduced. So then this way here, unfortunately, it creates this severe loss of fluid. So there are RPs, polyuria, polypsia, nocturia, proteinuria, diluted urine, dehydration. Do you guys know what polydipsia is?
Yes.
All right. So if we need to test for DI, this is what we're going to be using. Diagnoses, outcomes, and then this is like a real breakdown here of everything that we just talked about. All right, SIADH. So, SIADH is going to be too much ADH. When we have too much, it's going to do water retention, which is then going to create hyponatremia. Decreased serum osmolarity, and then we're going to go into the causes. So, so what ends up happening with our hyponatremia is the fluid that's reabsorbed by those renal tubules, they continue to build up in our bloodstream. When they continue to build up in our bloodstream, it dilutes the blood, which is when they start to call it overload or retention. When that happens, it causes what is called dilutional hyponatremia. And we are going to see that usually when we have a sodium level less than 135. All right, so with SIADH, I want you guys to know that some signs and symptoms are going to be headaches, muscle cramps, weakness. Weakness also will go to fatigue. Your sodium level is going to be less than 135. You will have this weight gain without edema. So that also includes non-pitting edema. So if we're going to be testing for SIADH, I want you guys to think of two different things. When it comes to the urine, what is popping up all the time? When it comes to the urine, I want you to think for SIADH that it's going to be concentrated, super concentrated. And when it comes to the blood, I want you guys to think of that as super diluted. So if we are looking to somehow, I don't know, let's say intervene on SIADH, first thing that we're going to have to do is we have to limit the fluids, the oral fluids for our patients. So we're going to want them to do 500 to 1,000 milliliters a day. So we could, that's like a good one for them. And it gives them some type of control with how much fluid they're actually getting. But the first thing that we're going to have to do is we're going to have to limit that. What else? We are going to have to be very strict with our guys. What is going on? We have to be very strict with their eyes and nose. Maybe this just doesn't want me to do anything with the PowerPoint. The second I walk away, it's gonna. Okay, so if we are talking about IAH, and we are talking about characteristics of it, if, I'm sorry, tell me what SIADH is. Tell me what is going on. How much or how little, what's going on with the ADH part?
Too much.
Yep. So that is going to be a definite characteristic. And what about our fluid? Which is also
Or dehydrated.
No, it's either retention / overload. So our fluid is going to be overloaded in SIADH. And then tell me about our. It's definitely decreased, right? And what do we call that? Yeah. So if we're talking about SIADH and I want to know 3 characteristics, those are them. Okay. All right, so let's say that we are taking care of somebody who has SIADH. What did I say the number 1 priority that we're going to do?
Monitor
eyes and nose.
very strict on their eyes and nose, and
The monitoring is going to be second.
but limit their intake, their
Yes.
fluids to 500 to 1,000 milliliters. And we
Corinne,
control the
thank
ice
you.
strip.
I'm about to like lose my shit on this. All right. Yeah, so first thing we're gonna do is we're gonna limit intake. So if you guys were to see something on the test regarding that, I would say that it has to be anywhere between 500 to 1,000, 800 to 1,000. It has to be between 500 and 1,000. So if you guys see 600, 1,000, 700, 1,000, that's fine. But it has to be between 500. Okay, so SI-ADH, another way to remember that means that you're soaked inside with the SI. If we're talking about diabetes insipidus, you guys are going to be dry inside. Okay. And the delusional hyponatremia is what, below what number?
135.
All right, and then if we are thinking that somebody is currently having a episode of DI, diabetes insipidus, what would we expect their urine to be? Fast, slow?
Wouldn't it be fast?
Yeah, there's going to be increased urine output. Amen.
Starting from,
11?
no, she was
I was doing it all.
zooming in on the picture.
All right, growth hormone imbalance. We talked a little bit about this last week. So if you have a child who doesn't seem to be sizing up with the other kids, you're probably going to talk to the pediatrician and say, hey, my kid's like a foot shorter or a foot taller than all the other kids. And they're going to want to run the growth hormone test, and they're going to see like, hey, do they have too much growth hormone or do they have too little growth hormone? Does anybody know what the primary function of growth hormone does? Just think about what growth hormone is, right? If it's working, then it's doing blah. If it's not working, then it's not doing. What happened? So growth hormone is, the primary function of it is to promote the growth and development of bones and tissues. That makes sense now, right? So if a child is lacking growth hormone, or even human growth hormone, right, HGH, then they are not developing. That hormone itself is not promoting development with the bones and the tissues. If it's normal or if it's overactive, then it's promoting like a fast growth or a normal growth. Does that make sense? So here are some signs and symptoms in adults. And some nursing care. All right, so acro, Magali, you guys don't have to worry about it medically. This is just when you have too much growth hormone. Like Frankenstein, you said, had this. There was another one too. Lurch for like the Addams Family. Andre the Giant, that from like Princess Bride. All right. All right, so thyroid. If we have not enough thyroid, like a lacking of thyroid, it's going to be hypothyroidism. If we have a abundance of thyroid hormone, that's going to be hyperthyroidism. Yes. So here is a really cute avatar, and I feel like now it's all starting to make sense. All right, so if we are lacking thyroid hormone, it seems like everything is just gonna underproduce. So you are gonna have weight gain, your cholesterol is gonna be high, you're gonna have super dry skin, constipated, there's gonna be hair loss, you're always gonna feel tired, there's gonna be a sensitivity to the cold, and again, all of this is because you have an underactive thyroid. If you have an overactive thyroid, it's the complete opposite. You're gonna have moist skin, there's gonna be anxiety, you're gonna have high blood pressure, instead of gaining weight, you're gonna lose weight, excessive sweating, trouble sleeping, and fine, brittle hair. So this is what happens when you have too much. So hyperthyroidism. So some of these, they're a little outdated. I like the other girl better. All right, so for hypo, and we are going to have questions regarding hypothyroidism. So let's see what we have here. And we'll start with hypo. All right, so if I was to ask you guys 3 signs or symptoms, which is going to be on here. I'm going to ask you guys if dry skin is a sign of hypo.
Yes.
I'm going to ask you guys if constipation is a sign.
Yes.
And then I'm also going to ask you if bradycardia is a sign.
Yeah.
Thank you. There's your tableau. Clauses. Here's some signs and symptoms. Let's see if it's here. Do you guys remember what we call the enlarged thyroid? And when it comes to their diet, people with hypothyroidism, let's see if it says anything for our interventions. Okay, when it comes to their diet, we want to increase their fiber. Why do we want to increase their fiber?
Constipation.
They're always constipated. You guys are not going to have to worry about the myxedema function. All right, so if somebody has chronic hypothyroidism, and I gave you guys 4 different answers, I'm going to ask you guys, which one are you going to report to the provider immediately? What immediately comes to mind, NCLEX testing wise? If you ever repeat something immediately, what are we thinking? We want safety or priority, right? like,
Slow
if I'm going
out.
right along the rider, somebody's injecting a gun, right? Okay, so if I was to say to you guys, you have a hypothyroid patient and they have hair loss in the bed. They have muscle cramping. Their heart rate is in the 50s, or they are like starting with a decreased level of consciousness. Which one do you guys think is the priority? Yeah, consciousness is always going to take, right? Because we know that when it comes to hypothyroidism, like we're going to have forgetful memory, but like level of consciousness shouldn't ever be involved when it comes to your thyroid, period. Can somebody tell me again what the growth hormone does?
Helps with bone and tissue growth. The growth and development of bones and tissue.
Unless you're a mom that lives in Fairfield and wants to inject your kid with it because she wants to be a model.
Lemon?
Unless you're a mom that lives in Fairfield and wants to do growth hormone injections because you want your daughter to be a model. I'm dead serious. I've been threatening technology for 40 years. Fairfield moms are the worst. My daughter's in 5 hours. She's going to be a model. She's going to become a So let's inject the parents and then stuff. All the time. It's a good time. Whenever they're called, like, I don't even know if your daughter's pretty enough to be a model, so I would. They were ridiculous. Or my son is 5'8", my second son's like 5'6".
That's crazy. All right, hyperthyroidism, complete opposite, like literally the complete opposite. So, intolerance to heat, bulging eyes. What did we say the bulging eyes was called? Graves' disease. That finger clubbing, which you guys all got. It's crazy. It's like when you read this, like a lot of these signs and symptoms, like the tremors, increased diarrhea, changes in your menstrual, muscle wasting, your blood pressure goes up, weight loss, your heart rate goes up, facial flushing, and then your intolerance to heat. These are all signs and symptoms of Ozempic. All right, so it increases your metabolic rate, increases your beta receptors. So for hyperthyroidism, we have too much thyroid hormone, and that is going to create a huge problem for us. So let's see what we have here. Okay, so pause is autoimmune Graves' disease. Our lawyer. Here are the signs and symptoms. We just looked at that picture. There's another one. So when we talk about our thyroid hormones, we are talking about our T3 and our T4. So in the elderly, they're gonna end up with heart failure, AFib, apathy, fatigue, depression. All right, so what I want you guys to know is that Graves' disease is a form of primary hyperthyroidism, and it results from impaired function to your thyroid gland. So your TSH level, that is your thyroid stimulating hormone, is going to be below the expected range. And that is because the thyroid hormone level is high. Thyroid storm. So this is also called a thyrotoxic crisis. Thyroid storm is hella scary, and this patient immediately goes to like a critical status. So if we had a patient who ended up in thyroid storm or thyrotoxic crisis, their blood pressure is up, their heart rate is going to be up, they're going to have a fever. And when we say fever, we're talking like 104, not like 100.4. Respirations are going to go up. So what I want you guys to know is that the treatment for this, let's see if it, interventions. Okay, our treatment for this is going to be several different things. So first thing is we need to treat towards whatever the life-threatening issue is. So if it's the fever, we are going to give the acetaminophen. When it comes to the tachycardia, we're going to give probably propranolol, I'm thinking. If we are talking about the overheating, it's going to be IV fluids, it's going to be a cooling blanket. What we don't want to do is, first, we don't want to give aspirin because it's going to bind to your T4, and T4 is part of your thyroid. That's why we don't want to give aspirin. We don't want to give epi because our heart rate is already above, so it's really only going to make everything worse. And with that, you're probably going to end up compromising your airway because of the thyroid. And I guess, so all in all, I'm thinking if we're going to be giving the propranolol, that's beta blocker, right? So we'll do beta blocker and a cooling blanket and IV fluids. That's probably, and the acetaminophen is probably your step 1, 2, 3, 4. Sound good?
Mm-hmm.
So if we do give propranolol or a beta blocker, right? Tell me what it's going to do. Yeah, so it's definitely going to decrease that fast heart rate. It's going to help with that blood pressure. And also, if we know that tremors is a part of hyperthyroidism, and now we have a patient that's in hyperthyroid or just thyroid storm, we know that their tremors are going to be off the hook. So if you are giving them propranolol, it's actually going to help with the tremors as well. Do you guys know why the body needs iron?
Yes.
Iodine, sorry. Did I say iron?
Yeah, you said iron.
How'd you know I wanted iodine? So good, Mary. Yes. Fair enough. But you're still so good. Do you know what the importance of iodine is in the human diet? It regulates something. And we are talking about thyroid hormone.
Regulate your thyroid.
What?
Regulate your thyroid.
Say it again.
Regulate your thyroid.
It regulates the production of the thyroid hormone. And then it also is going to prevent a goiter. Nope, it helps to regulate the production.
Either way.
Yep, it regulates the production. And it helps to prevent the enlargement of your thyroid gland, which is a goiter. There it is. It looks like somebody swallowed a tennis ball and got stuck. So usually you're going to treat the cause, which is going to be hypo or hyper. But what ends up happening is you end up getting a thyroidectomy because it will grow and grow, and then that creates like difficulty with breathing, and it starts to press where it becomes hard for them to swallow.
Does the thyroid grow back after you get it removed?
It can if you don't actually treat the problem. So like, if you don't treat the problem of too little or too much of that hormone, thyroid hormone, then yeah. 100%. So this is just going to be hypo and hyper. And it's like a little breakdown for you by system. Again, they're complete opposites. This is just some stuff that you end up with. Cancer of the gland. Yeah, they take it out and it usually doesn't spread. All right, thyroidectomy. There are a couple on your test results, just FYI. So, let's find the first one. Let's see. All right, so here is some pre-op teaching, support the neck, consensus barometer, gentle motion, post-op, some complications, that thyroid storm technique. All right, parathyroid hormone, so hypoparathyroidism and hyperparathyroidism. So this is just the decrease or the increase in the parathyroid hormone. Some signs and symptoms of hypoparathyroidism. Have you guys done this in lab? No? So what ends up happening is, if somebody has a positive Trousseau's, they are going to use a blood pressure cuff and the hand itself is automatically. So as you're pumping that blood pressure cuff, like without the patient even realizing, like the hand is turning it. It's really bizarre. There's like a ton of videos on it because it's like every doctor in the world, as soon as they see it the first time, let's take a video and pretend like they're the first ones that saw it. So, interventions for hypoparathyroidism is going to be IV calcium gluconate. Long-term is gonna be oral calcium and vitamin D. So, if we're giving somebody IV calcium gluconate, or for long-term, we're giving them oral calcium, what do you think the calcium levels on somebody with hypoparathyroidism looks like? Yeah, they run low. They run really low. And because of that, they have to be on calcium for a very long time. That is also going to be the same. That is also going to be the therapeutic intervention for the tetany, because that is caused from a calcium imbalance as well. If you have somebody who is, and just think of this like on like a bigger level, if you have somebody who's having muscle spasms, especially in their lower extremities, and when we say muscle spasms, let's think like Charlie horse muscle spasms. What are they lacking in their diet? And if we're talking about thyroid stuff,
You're gonna say phosphate?
calcium, we're lacking calcium. So if you know somebody has an endocrine issue, especially if they're like hypo anything with endocrine issues, your calcium is always going to be the number one thing you're going to want to check. All right. When it comes to the heart, our potassium is always going to be the number one thing we want to check. But when it comes to endocrine, calcium is going to usually make or break whatever it is that we're looking for, or at least those levels will. I think I had a question. All right, so here are signs of hyperparathyroidism. Here's some diagnostic tests. So with hyperparathyroidism, you're going to see that the calcium is going to be elevated. So then we're going to have to do a 24-hour urine blood just so that we can test the urine. Here's our interventions. Diagnoses and activity. This is just the adrenal cortex hormone imbalance, and this is where we're going to start talking about Addison's and Cushing's. So, there are two right. All right, Addison. So it is deficient in cortisol. With that, you could also be deficient in aldosterone or androgens. Causes for Addison's is going to be autoimmune, cancer, AIDS, period, or hypothalamus problem, or an abrupt discontinuance of long-term steroids. Here are your signs and symptoms of Addison's disease. What is the number one sign and symptom you guys see up there?
Hypotension. No.
So, if you guys have a patient and let's say they have a history of Addison's.
Hypoglycemia.
Say again?
Hypoglycemia. Is that the one?
That sounds different.
Oh, yeah, there is a bronze, yeah, these are people with bronze skin. I was like, what?
Isn't that the Kennedy disease?
Oh, is that what they call it?
Oh, wow.
Isn't he got Addison?
I don't know, I just thought it was out at Market Thing too long.
Yeah, I think they call it Kennedy disease.
Yeah.
So anywho, if we have a client and let's say they are getting some kind of surgery no matter what, if there's any kind of history of Addison's disease and this patient starts to go hypotensive, that is always going to be a wrong priority. So if all of a sudden, I don't know, let's just say I'm trying to think, let's say we did a post-op, or you know, we had them because they went in for a skin tap removal. Right? The next thing you know, now they're hypotensive, and you know they have history of Addison's disease, that's your priority. Because when they tank, they're going to take it fast. Kennedy. All right, so here are some of the diagnostic tests. Complications, so Addisonian adrenal crisis, so I've heard it as adrenal crisis. Addisonian makes sense too. This is when your patient is so dry on the inside and so dehydrated that their sugar is low, their blood pressure is low, their heart rate is low. Everything is low because I want you to picture the inside of this patient like a raisin. So if somebody does have Addison's disease, I want you guys to know that in order for them to regulate it, also like is they are going to be on steroids their whole life. Like, here it is. Glucocorticoids or the mineral corticoids are going to be really for life. Double or triple in times of stress, and you want to promote a high sodium diet. So, if you have a patient that's like, hey, I think I'm going to stop taking my steroids today, I feel perfect. This is the same mentality as anybody that's on like psych meds. They finally, like let's say it's depression or anxiety, they finally hit a point where they feel magnificent. And they're like, all right, I'm back. I don't need these drugs anymore. The only reason you're back is because the meds are finally gone. Stay on the meds. If all of a sudden now with these steroids you finally feel like you're back, stay on the meds. Don't go off the meds. Let's see what else. All right, never abruptly discontinue long-term steroids. And this is what Addison's is going to look like. I feel like we see this every day. Cushing's. All right, so this is when we have too much adrenal cortex hormone. When it comes to Cushing's, I want you guys to know a couple things. Cushing's, these people are going to have moon faces. They're going to have a buffalo hump right here. And they are going to have this purple striation. And that is usually gonna be right here in the belly. It's gonna look like stretch marks, but it's gonna be purple, like purple like the Bruce almost did, purple. So, again, he has that moon face. He's got that purple striation on his leg there, but you can also see it in the belly area. And because he's facing us, we can't really see the buffalo hump, but they all have a buffalo hump. It's usually between the shoulders. All right, so signs and symptoms. So they are going to have salt and water retention. They're going to have hypokalemia. Women are going to have facial hair. They're going to have that buffalo hump, moon-shaped face. We talked about those purple striations. So these are going to be the different diagnostic tests that we are going to give. Here's some therapeutic interventions. So surgery if it's a tumor. If they are on a steroid, we need to reduce it. They have to be on a low sodium, high potassium diet. So if we have somebody that has Cushing's and we have to do some kind of dietary modification, it's always going to start with sodium intake. 100%. Here's some nursing diagnoses. Adrenalectomy. This is just going to be taking off the adrenal gland. If we are sending somebody for blood work to measure their TSH, their thyroid stimulating hormone, what are we actually doing? Like, what are we trying to determine? If the thyroid gland, yeah, so we want to, if we're setting somebody to look at TSH, like, we want to know, is the thyroid gland overactive, underactive, or is it just normally active? Does that make sense?
Yes.
So I don't know if it was out there or not regarding Cushing's, but there are so for Cushing's syndrome, I want you guys to just know that the people who are more prone to get Cushing's are going to be people who are on long-term steroids, people who are going to have like pituitary like tumors and cancers, and people who have cancer who are currently in chemo. Okay, so we got really 130. Yeah, it's like it's fine, but. All right, 21-year-old female patient, history of SIH. What did we say for SIH? For feeling full and rapidly, muscle cramps, your serum osmolarity is 220, so it's low. With assessment finding requires immediate follow-up. The full feeling, muscle cramps, fatigue, or yeah, it's low. 52-year-old male patient is admitted to the ER with statements of severe pounding headache, blood pressure 220 over 120. Yikes. 24-hour urine test for, yeah, sure. What are we doing first, guys? One.
Two.
Which assessment is most important for the patient with SIH? Thank you. Signs and symptoms with hyperthyroidism. Remember, this is like the patient who looks crazy. Nope, they're gonna have moist skin. Yeah, 6 is gonna be that breeze. And which assessment finding in the post-thyroidectomy patient should we report STAT? It is tingling. And which diagnosis is the priority for the patient with hyperparathyroidism? All right, did anybody look at chapter 40? No, we just did it.
No, that's formally, no, that's it.
Yeah, it was this cute little verbal that we did. Let me just make sure that this is gonna be DM1 and 2, and I'll be able to let you guys know.
I just need to know the kind of drug. I think I booked.
Oh, good.